Also want to invite, if we have questions for the panel or comments for the panel from the audience, please feel free to come up to the mics. Any other thoughts about that waiver of consent issue and how that interacts with this, or how this OA draft guidance would affect that or not?
Well, the regulations require that one of the criteria for waiver of consent is that it not adversely affect any of the participants' rights and interests. And in my view, failure to describe and discuss the ways in which randomization alters consent is problematic, even if, say, the alteration of risks of harm is minimal. That's simply a failure of respect and the opportunity for autonomous choice. So, that little phrase in the regulations nobody really knows what it means to say, there's no effect on your rights or interests, and so that makes waiver of consent okay. But I think in this particular case, focus on risks of harm only does a disservice to potential subjects.
Looks like we have a line back there. Rob, go ahead.
Yeah, and this has been a fabulous discussion. What concerns me, though, is that it relative to the most important questions today, at least from my biased perspective, it's ignoring the fact that we do need very large numbers and that the theoretically ideal thing to do is simply not possible if you want to answer these questions. And I could list a long list, but I'll just give an example that's in play right now with Picornat. Now, you'd think 100 years after aspirin's on the market, we'd know the right dose for secondary prevention. We know it prevents death and heart attacks, but we have no idea what the right dose is. In America today, about 55% of people get full-strength aspirin, and about 45% get baby dose aspirin. If there's a 10% difference in effect of this almost dirt cheap medicine, and everybody got the right dose, it would save something like 90,000 lives a year globally, because this is the leading cause of death and disability. But the sample size needed to detect that effect is somewhere between 15 and 20,000 people, depending on other assumptions. And if you want to look at important subgroups and be able to say anything meaningful, you're talking about 40,000, most likely. So you just take a conversation, multiply it by 40,000, and the cost of the personnel involved in doing it, and it's out of the range. I was on a call last night with NCI, which is funded almost 2x compared to the next NIH institute, and they're essentially abandoning long-term prevention trials because they can't afford to do them. So we're sort of, I like Bray's question, what if we don't ask the questions? And I think this afternoon it's likely we'll get into a very interesting discussion about this, but it'd be interesting to hear from this panel. Are people capable of consciously making the trade-off between not answering a question, consigning a lot of people to needless death because we don't know the answer, versus not doing the ideal job with consent because the cost of it is more than our funding agencies are able to pay for?
Again, I think I want to repeat part of what I said before, but I think I agree with your point. But I think the ideal job might be when you're prescribing the aspirin, say, we're not sure which of the two doses is better, so what we're doing in this clinic is that we're randomly choosing which one you want. If you have some reason that you prefer the higher or the lower, you don't have to be part of this study, but otherwise, my recommendation is that we should randomize you because ultimately we'll eventually learn out which of these two is a better one.
But you would not be in favor of describing every potential side effect of different doses of aspirin?
I would.
Take 30 minutes.
So this is what
Yes.
what I heard you say is very sensible, and it sounds like Kim Miller to me.
Yes.
But I think what the guidance says would then, we would pop out a 40-page consent form about every foreseeable risk and put it from a patient who would then blindly sign something because there's no way they're going to read this, and the patients know better informed at the end of the day.
So, Rob, it seems to me that you're turning an ethical question, bioethical question, into a resource allocation question.
That's not ethics.
Pardon?
Resource allocation is not ethics.
Yes, that's right. But to answer that resource allocation question, you're going to have some evidence about
and I
the
think-
marginal effect of going all out with informed consent.
And I think Rob's question gets to this reasonably foreseeable threshold, which we'll have a whole afternoon to talk about in terms of, what does that have to do with the magnitude of the event, the differences in probability, and how does that figure into reasonably foreseeable, and who decides about that? Question from over here?
Fleischman, Einstein, Montefiore, New York. I think with Ben's comment, we get closer to my question. And that is, we've been talking on the panel as if there are researchers over here and clinicians over here, and they have separate interactions with patients. In fact, the vast majority of research is being done by clinicians in their private offices or in their clinic offices. And I wondered if the panel would consider the impact of that reality on this whole process.
I wrote a note to myself, the question, after all this, shared decision-making in my clinical experience, patients often say, well, what would you do? Because that's sort of their equivalent of saying, could you give me the drug that the white people get? What would you do if it was you or somebody in your family? What you're saying is maybe they would say, well, I would go in a clinical trial because I have no idea. What I always wonder is, what would my patients think of me then if I said I had no idea? Other people's thoughts about that?
Well, I think that the problem of viewing the clinical world and the research world as totally separate is artificial. But I also think that that's exacerbated by the perception that OHRP really wants everybody to write 50-page consent forms. One of the things that has been discussed a lot recently, and I'm not sure whether to call it a decision aid or just a different model. Long ago, again, Jay Katz again, he proposed a way of thinking about research consent that was, well, let's have a really short form that explains the things that people really need to know about the experience of consent, and then let's have a bunch of appendices with additional information. And of course, the key there is to get everything conveyed in a meaningful way to research subjects. But the idea of plunking a whole bunch of incomprehensible information into a consent form is not what the regulations have in mind. And I think actually that there's a real potential for the draft guidance to be misread in that respect. I think that what really has to happen is that clinical investigators need to think more like clinicians. I never thought I would say this because I think there's a real problem with blurring treatment and research. But clinical investigators and clinicians have very similar interests in terms of building a relationship of understanding with patients and research subjects. And the processes shouldn't be as far apart as they are now. I mean, there may be a lot of IRB overkill on the research side, but there is, as we've been talking about, a lot of information underload and information disparities on the clinical side, simply because the sort of legal and social and structural way of addressing consent to treatment is very different from the regulatory model of addressing consent to research. And that's, that's an artificial systemic problem that we have to figure out how to solve.
Well, okay, so the artificial divergence, I think, it absolutely exists, but I'm not sure how we're going to heal it, and I don't see this guidance taking us any closer in that direction, because you have the spirit of the guidance, then you have the letter of the guidance, which is what the IRBs are going to cling to. And I think it's going to be much easier for people to do exactly what you said. Take a whole bunch of information, shove it in informed consent, and call it good. But again, we don't have a better informed patient, and now we have an onerous process.
I'd like to make a comment on the topic of informed consent about randomization. I think we've concentrated too much on the consent form itself, the written form. The written form is a proxy. It's a proxy that is used to protect people from mischief in communication. But the other day, I bought a battery. I had 9 pages of consent information in 4 languages, none of which actually I read, because the print was too small. But in the tyranny of the consent form, as we think about teaching about randomization, which I believe out of respect for the subject we ought to do, we should not focus only on this written consent form. There are 25 feet of research papers on how to teach probability to children, middle schoolers and high school in general. And we need to take some of that information and try to use other means of communication. I believe we can and we ought to do a lot better on teaching this. I should say, in terms of the gumball example, at least research with children would suggest that's not the best way to teach about probability. But that's for another time. Probability is probably one of the most difficult things that math teachers in high school and middle school have to do, and that's why there's so much research on it. We ought to look at it.
John Tyson from UT Houston. A couple of points. It seems to me that the question of resource allocation is fundamentally an ethical question. So the decision of whether we spend money for schools or pregnancy prevention or randomized trials or patient care is a decision based on the values we have. The second point I wanted to address is the issue of the disparity, the double standard for consent for use of unproven therapies in patient care versus in research. To me, the discussion should not be very different, and the problem in getting clinical trials done is so often hinges on that disparity. In neonatology, for example, we still don't know whether you should clamp the cord right after birth or wait 30 to 60 seconds. And part of the problem of getting that trial, large definitive trial done, is issues with the double standard for consent of what you do in clinical practice without even mentioning what the risks and benefits might be versus what you would say in clinical trials.
Don Brunkwell from Minnesota Children's Hospitals. I'm going to tread perilously close to paternalism here, but recognizing the difficulty that was highlighted in the talks of creating knowledge in research subjects, I wanted to ask the panel to think a little bit about the role of the IRB in determining whether subjects should even be allowed or permitted to assume the risks of a trial. I mean, I'm not saying we shouldn't inform people. We clearly should inform people. But is there a stronger role for IRBs in determining whether the trial should be allowed to go forward and whether the randomization procedure is reasonable and that people should be allowed to assume those risks? And how does the composition of IRBs relate to that as well, and inclusion of non-researchers on IRBs?
Somebody else may know more about this than me, but you know, I think it's in the Federal Register notice accompanying the draft guidance. 45 CFR 46, you know, does pretty clearly address, you know, that IRBs should consider reasonably foreseeable risks in their gatekeeper function in terms of saying should this trial go forward. So I think that's all that's already there. I think we are here today talking primarily about once a trial has made it over that hurdle, what should happen in talking with individuals. But I was saying this discussion probably already presumes that a potential trial has made it over that hurdle.
Is the experience that you have that IRBs are in fact doing that?
Can you clarify, are you talking about IRBs making determinations based upon risk or based upon scientific validity? I wasn't clear which of those you were asking about.
Actually, including both of those in there, what the risks are to the subjects and the scientific validity, and whether that bears, the risks of the research are justified by the scientific validity.
No, IRBs are very clearly charged with that responsibility. I can say the one I sit on does that. I can't speak for all of them, but that's very clearly in existing regulation.
Okay.
Well, and let me just add to that. I'm not exactly sure why you said you were treading near paternalism, but I know there is a perspective out there that says that IRBs get in the way of investigators and potential subjects making choices to do whatever they want. And when IRBs say a study shouldn't go forward, that's paternalistic. Well, I disagree completely with that reasoning. Investigators and IRBs and the research enterprise have a duty to move research forward that has an appropriate balance of harms and benefits, that has a social purpose, that is scientifically valid, and because the research goal is to learn, not to benefit individual patient subjects, the goals are different. There is a scientific duty to view research in the way that the regulations curtails it. And it's not paternalistic to say really risky research should go forward just because some people think that they want to participate in it or to conduct it. And that goes back to the Nuremberg Code.
Nancy Roach, and I'm a patient advocate. And actually, I'd like to follow on with what you were saying, because there was a study that Rob did, that looked at clinicaltrials.gov that found that the vast majority of trials in clinicaltrials.gov were single institution, small phase 2 trials that weren't going to do much of anything. And so that makes me go back to, okay, if that's the IRB's job, then I don't think IRBs are doing a very good job in the enterprise. And in terms of what y'all are talking about, it strikes me that when I take my car in to get fixed, I take it to a couple mechanics and get bids. The same thing when you do construction. And I do think we're kind of being unfair to patients when we say you need to basically almost turn into a doctor in order to make a decision about a trial. And I say that with 20 years of experience. The more experience I have in this, the more I kind of tend to step back and say, you know, I don't know. Why don't you go get another opinion? I mean, I think we're harming people to death by overly protecting them in the system. And Bray, I'd wonder if you could comment on that.
I don't know if there's much to add to what you said. Again, I mean, I think this is true, and the gentleman that just spoke, I was really trying to wrap this back around to what we're speaking about with the standard of care research. I mean, if something is a standard of care and we haven't bothered to study it in great detail, and now we're at a point of doing CER or something like that, I do feel like we're at a place of overprotecting patients. We're slowing research down so much that I think we have to accept the fact that there aren't endless resources. Many clinical trials are failing to get off the ground. Those that do get off the ground are failing to enroll. And we have to make some major transformative corrective changes to this system that is going to be much broader than what we can do today. But I do think that IRBs are institution-centered and not patient-centered at this point.
Can I say one really quickly? One of the things that we learned from our focus group and surveys is that what's really seems to be very important to patients is, similar to what you said, the issues of trust and the relationship with their providers. And once that has been established, that seems to be the driving force in people's comfort for participation in research. And I think that's where more of the action is trying to figure out how do we foster that trust and improve those relationships.
Can I just make one follow-up? I mean, it's sort of I'm trying to say this as circumspectly as I can, but the resource allocation question is an ethical question at a different level. And it troubles me that the response to it costs too much to get informed consent would be, well, let's just skip it because we need to get the research done. There have to be other ways to address the resource allocation question. I mean, I understand the frustration that would lead to we need to get more stuff done, so let's just, you know, skip all of this ethics stuff. But
That's not what's being said.
Yeah, what about?
well, I'm kind of.
So Nancy, what do you think of the Kim Miller model?
I think it has a great deal of usefulness. I like it. It was on one of my slides, along with Chris Feutner and John Lantis's article on comparative effectiveness research. I think it's very useful, but I think we have to think really carefully about using solutions that undercut informed consent simply because we need to get research results. We have to balance that with the good things about different kinds of options like Kim and Miller have written about.
So from a patient perspective, following on to what Nancy said and what Bray said, which was a little bit of what I was going to comment on related to paternalism, whom are we protecting human subjects, and we are people and patients, from? And are IRBs really protecting the patients, or are they protecting legal issues related to institutions and researchers? And my third point related to that is it's not 1979 and it's not 1991. And I know that's not why we're here, but we can't ignore that world outside when you open the door, and the fact that the information that's shared between a patient and a provider or a researcher is not just in that room with the door closed anymore, that there's a lot more information and things going into the decision making. So I just wanted to clarify that as we look at that guidance, that the audience it says the general public and patients, but I don't know anybody, and I hang out with a lot of patient nerds who are going to sit and interpret that and apply it in a meaningful way.
Thanks very much. I think we probably need to close the discussion so we can have our reserved time for public comment. Steve, do you want to? Okay.
So my name's Walter Strauss with Merck & Company, but I'm here as a public citizen. So I'm wondering about the issues that are raised that Miriam introduced with illiteracy and numeracy, then elaborated around diversity and resource allocation, and wonder whether some of the topics in this standard of care debate and comparative effectiveness research invite peer-to-peer consent procedures as opposed to formal medical provider, healthcare provider consent. It seems to me that there's it's very conducive to a formal evaluation in this setting.
Yeah, the nods around the table are a cool idea, and I think there's plans to talk about that later.